Thank you very much for your kind introduction, Fraser, and good afternoon, everyone. It's a great pleasure to be invited to contribute to this meeting. So what I'm going to try and do over the next 15 minutes is just provide a brief clinical overview of negative symptoms and give you a review of the latest information on their treatment. So, as we've already heard from Professor Yu, in schizophrenia we have a variety of symptom domains. So we have positive symptoms, which represent an excess or a distortion of normal mental functioning. So we have hallucinations, delusions, passivity experiences and thought alienation. We now know that cognitive impairment is a key part of schizophrenia. The deficits are widespread, and unfortunately they're present even when patients present with the first psychotic episode. And then today we're going to look at negative symptoms, which can be conceptualized as a deficit or a loss of normal functioning that all of us have. And these symptoms have been recognized for a long time. Professor Xu showed a nice photo of Kraepelin, who emphasized that loss of volition was a key feature of dementia praecox. And Bloiler talked about 4 A's, 4 key symptoms of schizophrenia. And one of these cardinal symptoms was affective blunting. Now, negative symptoms have been neglected until recently. And it's quite interesting to consider why that may be. Attention has largely focused on the psychotic symptoms. And I think that's because these symptoms are more dramatic. They bring people to the attention of accidents and emergency services, the police and so on. When patients hear voices, it's often very distressing to them. And of course our drugs, principally dopamine blockers, are effective in these symptoms. And when clinicians have an effective tool, they will always concentrate on treating that domain. It's just common sense. Now, in contrast, negative symptoms are less dramatic. They're quite difficult to recognise and diagnose in a clinic. Patients very rarely come to you and complain about lack of volition or I don't talk a lot. In fact, many patients aren't aware they've got these symptoms, and that lack of insight is more marked in the later stages of the illness. And I think we all know it's often the relatives, the mother and father, who complain about the impact of these symptoms. And then the fact that we don't have an effective modality to treat them encourages us not to spend a lot of time looking at them. And really this is a pity, because the negative symptoms make a huge contribution to the burden of schizophrenia. They are far more closely related to social and occupational outcomes than the psychotic symptoms. For example, negative symptoms correlate very strongly with your likelihood of being able to live in the community independently. They also correlate with the burden reported by caregivers. They're associated with greater healthcare resource use, particularly at primary care level. And they also have quite strong predictive element. So if you measure negative symptoms when someone presents with the first psychotic episode, that's quite a strong predictor of their functioning 7 years later. It's also predictive of the amount of resources that they will use over the next 8 years. These are a number of studies that measured the prevalence of negative symptoms. The symptoms have been broken down into different groups. I'll say a little bit about those shortly. But you can see these symptoms are common, and on average at least half of symptoms, so half of patients have got significant negative symptoms. It's important to appreciate that multiple factor analyses show that negative symptoms can be divided into 2 groups. And DSM-5 has encapsulated this 2-factor division. So let's look at these 2 factors. One factor of negative symptoms is diminished expression. So this is something you'll recognise when you talk to your patients. So they have blunted affect. They have a decreased emotional response to stimuli. They get less excited. You'll see a flat expression, you'll see a lack of gesticulation, their voice will be monotonous in tone. We also have alogia, or poverty of speech. This is a bit more complicated than is often written about in the books. You see the amount of speech being reduced, So when you talk to patients, they often answer with no or yes, rather than elaborating on the questions you ask. But you can also get poverty of content. So there might actually be quite a lot of speech there, but when you analyse it, it's conveying very little information. It tends to be vague and repetitive. So this diminished expression is one key domain. The second key domain is diminished motivation and pleasure. So patients describe anhedonia. They don't enjoy things they used to enjoy, following their football team, going out with friends, eating a meal, watching a film. And you can measure, psychologists will talk about anticipatory pleasure, the pleasure you have thinking about something you're going to do, and then the pleasure you have actually doing it. And in schizophrenia, both are reduced, but particularly the anticipatory pleasure. Then a second symptom here is apathy or avolition. So, typically someone with marked schizophrenia, their family will complain that the person sits in the house all day, doesn't go out, doesn't want to put the clothes on, stays in their night clothes. And then there's this asociality where, and this ties in quite nicely with the rat model that Professor Joe Neal showed you. There's a decreased interest or desire to spend time with others. So people don't see the friends. Often when family members come and see me, they'll say the relatives came to stay at Christmas or Easter, and my son just stayed in the bedroom. He didn't want to come down and have a family meal. See, this is another key negative symptom of schizophrenia. An important conceptualisation is to divide negative symptoms into those that are primary and secondary. So primary negative symptoms are central to neurobiological deficits of schizophrenia. These symptoms tend to be stable over time and predictive of prognosis, and they're seen in about 20% of patients. The other type of negative symptoms is what we call secondary negative symptoms. So these symptoms are secondary to something else, and I'll come to the sort of things that can cause them on the next slide. Unfortunately, when you see a patient with negative symptoms, there is no way for you to tell at a cross-sectional interview whether the symptoms you're seeing are primary or secondary. So here I'm talking a little bit more about negative symptoms. So these are some of the key things that can masquerade as negative symptoms. So depression, so you lack interest in things, you don't want to mix with people. Social anxiety, phobic symptoms could lead to asociality. Paranoia, if you believe people are trying to shoot at you or are going to kidnap you, you've got delusions of those natures, you're not going to want to go out of your house and mix with people, and you'll see that as negative symptoms. Drug side effects can cause secondary negative symptoms. In particular, think about severe Parkinsonism, where there's a difficulty initiating movement, bradykinesia. Think about sedation. Physical disorders, so sleep apnea, where people get a poor quality of sleep, and in the daytime they're often tired and are falling asleep. That can masquerade as negative symptoms. And many people live in an environment where there's very little social stimulation. Many of our patients live in poor quality housing. They live in not very nice areas. There's very little going on in the community. When they do try and get involved in the community, they're often rejected by others because of the enormous stigma that psychosis confers. And many patients internalise this stigma, so they see themselves as, in inverted commas, misfits or not wanted, and they actually stigmatise themselves. Management approaches. The impact of time to first treatment may well be important. So this interesting study was published some years ago by Millet, and he looked at two services operating in the same city. One was an early intervention model where there was education, referrals were encouraged, it was easy to get into the service, there was a low threshold for entry, and one was a traditional service. And he compared the people entering the two services. And as you'd expect, in the early intervention service, patients had a shorter duration of untreated psychosis. In other words, the length of time they'd been ill before the access to service was shorter. And their illnesses they had less severe negative symptoms when they entered. Once patients got into these two services, the treatment they received was virtually identical. But at 2 years follow-up, the patients in the early intervention service had less marked negative symptoms. So this suggests that getting people into treatment early and reducing the duration of untreated psychosis may protect against the development of negative symptoms. A great deal of interest in pharmacological treatment of negative symptoms, and Joe Neal drew attention to a number of companies that have tried to develop products in this area that unfortunately really haven't delivered the goods we expected. We have about 40 antipsychotics that are licensed. First antipsychotic was Thorazine, introduced in 1955, but none of these drugs has been licensed for the treatment of negative symptoms, and we have no licensed treatment at all for negative symptoms. This is a huge unmet need. I think what our two speakers have shown us is that one of the problems is that the mechanism underlying negative symptoms isn't fully understood, and related to that, we haven't, until maybe recently, had good predictive models, animal models. So if you don't have the model, you're unable to screen new molecules as treatments for negative symptoms. There's been lots of interest in psychosocial treatments for negative symptoms, including CBT, family therapy, art therapy. Art therapy is actually recommended for the treatment of negative symptoms in a NICE 2014 guideline. It shouldn't be, because there is no evidence it works, but it's interesting to note it got in there. Even if these treatments did work, and unfortunately there isn't a great deal of evidence they did, even if they did, we face a major problem that many of you want to give them for negative symptoms, and those patients are generally very reluctant to engage in treatments. So even if you did show that these treatments worked in a randomised controlled setting, I think there'd then be a further hurdle of were they effective in real-world clinical practice. Are any treatments effective? Well, I'll show you the latest data. This is a paper that was published online just a few months ago, December 2014, in the Schizophrenia Bulletin. It's the largest meta-analysis ever done of treatment for negative symptoms. So you can see that 168 trials were looked at. They're all randomised trials, and they're all compared to placebo. So the 168 trials were divided into three main groups. Those that targeted pharmacological treatments, and these were broken down into first-generation antipsychotics, second-generation drug combinations, anti-inflammatory drugs would be in there, adding antidepressants to antipsychotics, and adding glutamatergic drugs there. There was then a range of psychosocial interventions, including music therapy, cognitive remediation, and cognitive behavioural therapy. There were then about 10 studies that looked at brain stimulation, in particular transmagnetic stimulation. As you'd expect in a meta-analysis, the main outcome measure is looking at the difference in the reduction on a negative symptom scale with the drug versus placebo. Very big meta-analysis. You can see we're looking at over 11,000 patients. Various confounders were controlled for, and there's no evidence of any publication bias. Just draw your attention to a few key issues in the trials. You can see that the average trial is only 12 weeks, and this may well not be long enough to look at the efficacy of the treatment of negative symptoms. You can also see that the mean patient age was 38, and on average, patients have been ill for 13 years. And you could argue that by that time, negative symptoms have become very established. And there may be an argument that these treatments may have been more effective if they'd been looked at in first episode patients. We can't answer that because the data isn't there. Here's the main result. Okay, so here are the main treatments we've looked at. Adding in an antidepressant, using a second-generation antipsychotic, using a first-generation antipsychotic, using brain stimulation, using psychosocial interventions, or this miscellaneous group where you combined an antipsychotic with various other drugs. And there's the glutamate drugs there. And when you initially look at this, it looks quite promising. Okay, the first-generation antipsychotics and the brain stimulation, that is not statistically significant because the confidence intervals cross this line of no effect. But all these other treatments are superior to placebo. So you initially look at it and think, fantastic. But then when you look at the data in a bit more depth, it's actually very negative because all this is telling you is there's a statistically significant improvement over placebo. And we have to ask ourselves, were the changes clinically significant? And I'll skip this slide. The measure of clinical significance researchers used was, did the treatment show one severity step improvement on a CGI severity scale, or was it equivalent to at least minimal improvement on a CGI improvement scale? So these are really the lowest level where a clinician would look and say, that patient's done a bit better on a drug than placebo. And when you look at that clinical measure, no treatment is clinically significant. And as I said, this challenges some of our current guidance. So, NICE recommends art therapy. I think that was done on the basis of 3 studies, and actually only one of them was really an art therapy study. And overall, the result is negative. So evidence-based guidelines aren't often quite as evidence-based as people think. Now, there are some limitations of the analysis I've shown you. Firstly, you could argue the data I've shown you is over-optimistic. I showed you there was a statistically significant improvement over placebo, but it could be that improvement you're seeing is simply through treating depressive symptoms, social anxiety symptoms and psychotic symptoms. So if you want to take a very negative view, you could say the drugs are even less effective than I've told you. If you wanted to take a more optimistic view, you could say the studies were short-term. They didn't recruit patients who had predominantly negative symptoms. They analysed negative symptoms as one domain, and the CGI conversion was based on a global improvement measure. So you could argue, if you wanted to, that their analysis could potentially miss things. I'll mention one other meta-analysis to you, because I think maybe it's good to end on a slightly more positive note. There has been a lot of interest in the use of minocycline, which is an antibiotic, very well tolerated, and it has anti-inflammatory properties. And this shows a meta-analysis of placebo-controlled trials of minocycline. And you can see that there was a quite marked positive effect here. And we're looking at improvement in negative symptoms. And I particularly draw your attention to this study here done by Bill Deakin, Imran Chowdhury and Serdar Dursun from Canada, who's also at the conference. So let me summarise what I've said. Negative symptoms are very common. At least half of patients have them. Until recently, they've been very neglected. I've drawn your attention to this distinction between primary or enduring negative symptoms and secondary negative symptoms. I've told you that the negative symptoms are associated with poor functional outcome and higher healthcare costs. Unfortunately, the most recent meta-analysis shows that no treatment was clinically superior to placebo. I think we need a better understanding of the pathophysiology to develop better models and to screen for new pharmacological treatments. In terms of clinical management, I think it's important to get people with psychosis into treatment early, as we do have some suggestion that that may reduce the development of negative symptoms. I think it's important that we do screen for negative symptoms. We can do this simply by asking patients, tell me about your typical day, looking at their level of functioning. When we do a mental state examination, we routinely assess someone's objective affect and we assess their speech. It's important to treat secondary negative symptoms. Of course, when someone has negative symptoms, you rarely know whether they're primary or secondary, so I think you just have to try and treat everything you can. So if there's any suggestion of depressive symptoms, treat them. If the patient's got resistant positive symptoms, treat them. Make sure the patient hasn't got extrapyramidal symptoms. Try and get rid of any sedation. Look at the environment. Try and make it as stimulating as you can without stimulating a patient so much they become psychotic. Antidepressants, there is a suggestion from the meta-analysis that they can work. They're generally very safe drugs. They have few side effects. So I think it is often worth a trial of an SSRI. And finally, I think it's quite important to talk to the family about negative symptoms and explain that their son or daughter doing very little, not talking a lot, that reflects part of the illness, and it doesn't reflect them being the patient being difficult or awkward. And in that way, the family, you're helping to reduce stigma, and it may reduce high expressed emotion within the household. I'm going to stop there, and thank you for your attention.